Wait for 2 more minutes.
Yes, Suranga.
Ready? Yeah.
Yeah, actually, my camera, I'm joining in a different laptop, so then I cannot, my video is off. Is that okay? So no problem, no?
No problem. Yeah.
Okay, shall I start? Shall we
Yes.
start? Yeah.
Yes.
Okay. Dishan, shall we start?
Yes. You can
Yes.
start,
Okay.
Nala.
Okay. Good evening. Can you all hear me?
Yes.
Okay. Good evening, all of you, and welcome you all for the SIMCON 24 pre-congress workshop. This is the Advanced Medical Diagnostic Workshop. Today we are going to have a HRCT interpretation of HRCT. And first of all, I would like to welcome Dr. Suranga Manandama, the President, Sri Lanka College of Internal Medicine, to address the the workshop forum.
Thank you, Nalayani. Good evening, everyone. I warmly welcome every one of you to the Advanced Diagnostics Forum of Sri Lanka College of Internal Medicine. This is the first webinar of AMD series, and I extend a special note of welcome to our resource person, Dr. Sumudu Palihawadana, consultant radiologist, for joining with us today to enlighten us. And you all know the advanced diagnostics are crucial for physicians. Physicians are basically diagnosticians in their everyday practice, clinical practice. So empowering them to understand and interpret the latest diagnostic tools is vital aspect of their training. So we thought of introducing this AMD, Advanced Diagnostic Forum for the physicians from this year onwards. And so today, Dr. Sumudu Palihawadana will talk about how to interpret HRCT for physicians aspect. And I thank everyone for joining with us today. And again, I thank Dr. Sumudu for agreeing and joining with us today. And I thank Dr. Nalayani for conducting this, and also our GETS Pharma for giving the technological support. And I wish you all a fruitful 1 hour and learn something for the day-to-day clinical practice. Thank you very much. Over to you, Nala, to introduce Dr. Sumudu properly. Okay, thank you very much.
Yeah, thank you, Dr. Suranga. So today the pre-congress workshop will be on interpretation of HRCT for physician. The speaker is Dr. Sumudu H. Palihawadana. She is the consultant radiologist currently attached to National Hospital for Respiratory Diseases, Sri Lanka. She has been working there since 2017. So just an introduction about her. She's the graduate of Faculty of Medicine, University of Colombo. And she obtained her MD Radiology in 2008. And she got the fellowship in breast imaging in Royal Perth Hospital and fellowship in pediatric radiology in Princess Margaret Hospital for Children in Western Australia. She was the co-editor of Sri Lanka Journal of Radiology in 2014-15, and she was the honorary secretary of Sri Lanka College of Radiologists 2017-18. She was the academic secretary of Sri Lanka College of Radiologists in 2018-19, 19-20, and 21-20. She has been involving in supervision and training of post-MD trainee in radiology and chest medicine. She has had a very wide range of experience in radiology, and I am delighted to welcome Dr. Sumudu H. Palihawadana to give us an overview and the benefits and interpretation of HRCT. I would like to welcome you, Dr. Sumudu. Over to you.
Thank you, Nalini, for that introduction. And as well as, first of all, I should thank the College of Internal Medicine for inviting me for this forum. So I hope that I would be of some help or use during the next few minutes. So we'll see how it goes. Okay. Just raise your hand if I'm not heard well or I'm not seen well. So can you all hear Suranga?
Yes, yeah, we can hear you and we can see your screen also.
Okay,
but start from the beginning. It's you are at the 20-second slide.
Okay, right. How come that?
I think
stop
you can,
sharing again.
yeah, you can go up and
yeah. Wait a minute. How am I? Am I at the top now? Oh, I'm.
No, you are still at the 20-second slide.
Okay, right.
So just use this.
Yeah, I'm wondering why is it happening.
Just put the presentation view, slide view, and then you can go up. There's a slide view.
Yes, I'm there.
Yeah.
Just a minute.
You're not sharing the screen at the moment, yeah.
Okay.
Present
Present a bit, fine. Right. How about now? Not yet?
We can see the first slide.
But
You
we
can-
can't see the full
Yeah.
screen. So if you can put the slide view, then we can see the full screen slide view.
Use slideshow, the up. Here the slideshow is there. Yeah. If you click that.
How
Correct.
about
Yeah.
now?
Yeah.
You can see that.
Yeah.
Okay.
Yeah.
All done. Yes.
All
Yes.
right. So am I good to go now?
Yes. Yes.
Yeah,
Please.
okay. Sorry about that because I've never encountered that problem before. So, right. So now, so we are going to talk about HRCT or high resolution CT chest. So now it's a bit of a confusing area, to be honest, even for most of the radiologists. So I try to keep it simple as much as possible and also stick to the most basics and the most like the typical appearances rather than confusing you all with the very complex and the combined patterns of HRCT. So that in that way, though, you can so you would know the basics and so that you can build up your knowledge by reading further reading. So that is my aim. Right. So high resolution CT chest. So you know that it refers to a CT technique. So it's the diagnostic tool which is used to image diffuse lung diseases. So it is the technique in which thin slice CT chest images are obtained and post-processed in a very high spatial frequency reconstruction algorithm. So these are all technical, so you don't have to worry about it. So the basic ultimately at the end of the day, it will produce very exquisite lung details where you can identify even the very subtle changes in the lung interstitium. So now that we know that this HRCT is meant for diffuse lung diseases, so we have to talk, I have to tell a word or two about the interstitial lung diseases as well, because I'll be coming in and out of these interstitial lung diseases and HRCT during the course of the talk. So there are hundreds of interstitial lung diseases or diffuse lung parenchymal diseases affecting the lung parenchyma. But unfortunately, there are only very few HRCT patterns that are available for diagnosis. So that is where the confusion lies. So this is what I'm going to do in the next few minutes. So I will start with the basic radiological anatomy in HRCT and followed by introduction to HRCT patterns in ILD. And as time permits, I will show some of the common HRCT patterns that are seen in common ILDs, which would be helpful for interpretation. So I will start with the basic radiological anatomy in HRCT. So you all know that the smaller anatomical and the functional unit of the lung is the secondary pulmonary lobule. Now, I don't have to now, this is not radiology or anything. This is basic, I think, second MBBS anatomy knowledge, histology knowledge. So, so secondary pulmonary lobule is the part of the lung supplied by a single terminal bronchiole, which in turn give rise to about 15 to 20 respiratory bronchioles, which in turn end up in alveolar sacs and ducts. So that is the central core structure in the secondary pulmonary lobule. And now the rest of the secondary pulmonary lobule is composed of a network of what we call a scaffold. There's a scaffold. So that is actually the interstitium that we are going to talk, and that is the diseases, it's the diseases of the interstitium that we are going to talk of, not of the central core bronchovascular structure. So interstitial lung disease, when you say interstitial lung disease, so that is the part of the secondary pulmonary lobule that is going to get diseased. So when we consider the secondary pulmonary lobule, so I told you that this is like a hexagonal structure and it contains a central terminal bronchiole. And if you give some thoughts to the sizes of these. The distal-most pulmonary artery that is visible would be about 1 millimeter in thickness. And the distal-most bronchiole would be about 0.1 millimeter in thickness. Now, this 0.1 millimeter thickness is not possible to resolve with any type of imaging. So it's not visible to the naked eye. But we can see the distal-most pulmonary arteries and arterioles. Like I'll show you the examples. And then the interlobular septum, the septum of the secondary pulmonary lobule, that is also 0.1 millimeter in thickness, and that is also cannot be resolved with the HRCT in a normal person, right? And the visceral pleura also, if the thickness is somewhere like around 0.1, and again, that is also should not be visible in a normal individual. So what do we see? This is what we see in a normal individual. So this is an HRCT of the lung apex. So you can see some vessels in the periphery. I hope that you can see the image. And you don't see any bronchi or bronchioles, right? But as you go further proximally, the bronchioles and bronchi keeps on appearing. And you can see the bronchial structure in the center, but no bronchi in the peripheries because they are beyond the resolution of the CT. But if by any chance, if you happen to see them, then they are deceased. So this is the normal appearance of an HRCT. This is the appearance of an HRCT of a normal, healthy person. So we do not know the demarcations of the secondary pulmonary lobule in a normal individual, right? This is in contrast to a patient who is in cardiac failure. So a person who is in cardiac failure, what happens is there would be retention of fluid in the interlobular septum, right? So if you can see, now these are like, I hope you can see my pointer or the cursor. So we see this nearly, we'll call it hexagonal or diamond-shaped or multifaceted structures in the lung apex, which are the secondary pulmonary lobule outlined by the thickened interlobular septum that is due to fluid retention. So if you go, even here you can see some like a triangular area, which is again the thickened interlobular septum, right? And that is associated with thickening of the peribronchovascular septum as well. So here I'm like introducing you to the
Hello. Hello. Can't hear you.
I think we lost her voice, no?
Yeah. Sorry for the interruption. Just bear with us. She'll be joining soon. Hello. Any problem?
Okay. Right. Sorry about that. Can you see me now? I don't know what happened.
Yeah, we can see you now. Yeah. Yeah.
Okay. Sorry. Okay. Can you see me?
Yeah.
Right. Okay. Okay. Is it all good now?
Yes, yes.
Okay, right. I'm sorry about that interruption. Okay, right. So, so we are talking about the secondary pulmonary lobule, the interlobular septum. So, so what you see in the center is the thickened centrilobular septum, interstitium, not septum, actually is the interstitium. And what you see filling in the rest of the secondary pulmonary lobule is called the intralobular interstitium, right? So as we go on, I will introduce you to those parts of the interstitium separately, right? So what we do to image interstitial lung diseases or diffuse lung diseases, we use this tool called HRCT, that you know that. And the technique that we use now is called the volumetric acquisition. So because we have these multi-detector CT scanners, so we do not need to do this sequential spaced acquisition, which was very cumbersome. That is the one that we used to do previously. But now that we have volumetric acquisition with the multi-detector CT scanners. And the ones that we have here are very advanced, most of the scanners. So they are ultra fast, and we can acquire the images within milliseconds, especially the ones with this 128 slices above. So the patient does not have to hold the breath, which is a very good thing when it comes to patients who are really breathless. But having said that, most of the scanners that we have in the government sector are still 16 slice scanners, which still needs some bit of like breath holding, and there's bit of like they're not as fast as the newer scanners, like. So yeah, so routinely what we do is we go for a scan in full inspiration. So that is the basic building block, and most of the time it's followed by an expiratory scan as well. Now the prone images are optional. So if we have a doubt about basal stuff, what is going along the bases, we get down the patient back and do a prone scan, not on a routine basis. And we do the scans most of the time, especially with the 16 slice scanners. We start the scan from the bottom and go up. The reason being, since I told you these 16 slice scanners are not very fast. So we prefer to start from the bottom because most of the ILDs are along the base of the lung. So as we go on, sometimes the patient might become breathless towards the APC. Right. So the second part of the talk is introduction to HRCT patterns in interstitial lung diseases. Now, there are 4 questions to be answered. They are, where is the disease located within the secondary pulmonary lobule? What is the dominant HRCT pattern? What is the longitudinal and transaxial distribution of the dominant HRCT pattern? And are there any additional findings such as pleural effusion, adenopathy, or bronchiectasis? Now, the 5th one, I'm not going to talk about, right? So I will elaborate on these 3 because these are the most important things that you should be able to identify before reading an HRCT. Now, so these are the parts of the interstitium. So we have the centrilobular interstitium in close relation to the central bronchovascular core structures. So that is the centrilobular interstitium. Then we have the peribronchovascular interstitium, which extends along the central core structures, right? Then we have the intralobular interstitium filling the secondary pulmonary lobule. So the leaving aside the central core structure and the centrilobular interstitium. The rest of the secondary pulmonary lobule will be filled by the intralobular interstitium, which is also called the panlobular interstitium. Right. Lastly, we have the septal interstitium or the interlobular interstitium. Sometimes we call it perilobular interstitium as well, which wraps around the secondary pulmonary lobule. So if you can identify this, the components of this secondary pulmonary lobule, the interstitia separately, then it's very easy to identify the disease process that is going on. So there are 4 compartments. And the second question to be answered would be, what is the dominant HRCT pattern? So what is the dominant HRCT pattern involving the interlobular septum? What is the dominant HRCT pattern involving the centrilobular interstitium, intralobular interstitium, and the perilobular interstitium? So there are 4 of them. So first one is reticular and linear opacities, right? Second one is nodular opacities. Third one is high attenuation, which is due to either ground glass or consolidation. So high attenuation of the secondary pulmonary lobule. And lastly, low attenuation of the secondary pulmonary lobule. So it could be either due to emphysema, cyst, or airway disease. Right. So 4 of them. So everything comes in 4 in HRCT. Right. Now, so we know that there are like dominant HRCT patterns. Now we will go through them one by one. The first one is the reticular and linear opacities. So this is the list of reticular and linear opacities that you would encounter in HRCT. So we have the interlobular interstitial thickening. I have shown you where the interlobular interstitium is. Then the intralobular interstitial thickening, which is the part of the interstitium filling the secondary pulmonary lobule. Then the peribronchovascular interstitial thickening. Then we have traction bronchiectasis, honeycombing, and then this miscellaneous stuff as like parenchymal bands, subpleural lines, and fissural thickening. So we'll go through these now. So interlobular septal thickening. So I have already showed you a case of thickened interlobular septum. So when do you get thickening of the interlobular septum? The commonest clinical entity would be cardiogenic pulmonary edema. Now, we do not do HRCT to diagnose cardiogenic pulmonary edema. These are incidental findings, right? So sometimes also we get patients who have been presented, who come with SOB. So the clinicians think, oh, they are having some lung diseases, so end up having HRCT, but actually they are in fact having cardiogenic pulmonary edema. And so the septa are very smooth and they are very fine, and you have very sharp angles. So those are the things that you have to look for. Sometimes they could be associated with ground glass. I'll show you a real-time picture of this interlobular septal thickening. If you could appreciate this. These linear opacities, thin linear opacities, are due to thickened interlobular septum. So they looks like they are like, you can make up a hexagonal structure underneath, and then you have the vascular structures in between. So as we go down, usually, so this is the interstitial pulmonary edema, but as it develops, you can see there are foci of alveolar edema as well in the center of the secondary pulmonary lobule. Then we have interlobular septal thickening, which is smooth with central ground glass. And this is a typical picture of alveolar proteinosis. So we can see the outlining of the secondary pulmonary lobule, which is smooth. And the center of the secondary pulmonary lobule is filled with ground glass, and that is alveolar proteinosis. Right. Then we have another case where still we have interlobular septal thickening, but it is nodular. Now, the earlier one, it was smooth due to cardiogenic pulmonary edema. So this case, it is very nodular, right? I hope you can see that nodularity. So this is the case of lymphangitis carcinomatosis. And also we see that in sarcoidosis and pneumoconiosis as well. So I'll show you. So this patient is having lung cancer. So here at the top, we have interlobular septal thickening in the left apex as well. And the thickened septae are very irregular and thickened, and the thickening is mainly nodular. So that is nodular septal thickening. Right. Then coming to the next type of lineopacities, that is the intralobular interstitial thickening. So I've been talking about the intralobular interstitium. So that is the part of the interstitium which is within the secondary pulmonary lobule. So when it is thickened, it appears like a lace-like network of fine reticular opacities. So the commonest term used is lace or net-like shadows, as you can see here. So you don't see that thickened secondary pulmonary lobular outline as you see in cardiogenic pulmonary edema. This is a comparison. So on left side, you see the interlobular septal thickening versus intralobular septal thickening, where this along the bases, you can see this fine, it's like very granular appearance, not like the interlobular septal thickening. So that is the other case where you get lineopacities. Then traction bronchial ectasis. Now, what is traction bronchial ectasis? Now, in a normal person, I told you in the normal HRCT, the bronchioles, now within the peripheral most 2 centimeter of the lung, what you get is bronchioles. So these bronchioles are not visible to the naked eye in a normal individual. If they become visible, they are dilated, right? And in HRCT, we use this particular term called traction bronchial ectasis. I have seen a lot of our radiology colleagues and my train is also using traction bronchial ectasis, but actually it is meant for ILDs, because actually here the bronchioles themselves are not diseased. If just because of the peripheral fibrosis, they are dilated, right? So this is called traction bronchial ectasis. So you see it in the peripheral most lung. So if I am to show you it in a video, you can see that these bronchi extending into the periphery nearly to the base. So it should not be so in a normal individual. So this is traction bronchial ectasis. Right. Then thirdly, honeycombing. So honeycombing actually this is the end stage lung fibrosis. Honeycombing represents the end stage lung fibrosis. So they are thick-walled peripheral air-containing cysts based on the pleura. So they vary from like 1 centimeter for a few millimeters. So depending on the size, they are called either a microcystic or macrocystic honeycombing. So they can be made up of single layer or multiple layers. Earlier, it was like said that to call honeycombing that we need to have multiple layers. Now it's not so. Even a single layer with 2 cysts together can be taken as honeycombing, but whether it affects the diagnosis or not depend on the volume of involvement. So they have to be pleural based. If they are honeycombing, they are pleural based, and they indicate end stage lung fibrosis. So we have here 2 cases of very extensive honeycombing, and they are along the bases. And this is a comparison of the cystic spaces that you would encounter in the periphery. So here on the extreme left, you have honeycombing, the true honeycombing. And in the center, this is paraseptal emphysema. Now, this is again a single layer, but they can occur in multiple layers as well. So the difference is the walls are thin and there is no underlying fibrosis. So the underlying lung is normal. And then we have this newer entity called enlarged air spaces, right? So that is part and parcel of emphysema again, and they are not based on the pleura. So if honeycombing should be pleural based. It can never be away from the pleura. So what we see away from the pleura, these irregular air spaces are called enlarged air spaces. So that is what we call them. And they are just part and parcel of emphysematous processes. Right. So now I have been talking about these three findings: reticulation or intralobular interstitial thickening, traction bronchiectasis, and honeycombing, and they represent fibrosing from mild to severe grade. Right? So these are the features of fibrosis. So these are the HRCT features of fibrosis that you would be encountering day in and out in HRCT reporting. Now, these are minor findings, incidental findings. We often see subpleural lines and parenchymal bands. The difference is subpleural lines are parallel to the pleura and the parenchymal bands are perpendicular to the pleura. And they are seen in varying types of fibrotic processes and in post-inflammatory stages as well. Right. So out of the dominant HRCT patterns, now we have done linear and reticular opacities. Now we are coming to nodal opacities. Now there are three types of nodal opacities. So you would have heard these terms: centrilobular, perilymphatic, and random. So in the diagrammatic form that you can see in the centrilobular nodules are in the center of the secondary pulmonary lobule, and none are touching the pleura. So that is the most important thing to look for. None of the nodules are touching the pleura. Then coming to perilymphatic nodules, you have nodules here and there touching the pleura as well as in the central secondary pulmonary lobule as well as along the peribronchovascular bundle, right? But they are very heterogeneously distributed. They are not like homogeneously distributed as in centrilobular nodules. Then coming to random nodules, they are again like somewhat homogeneously distributed, but there are nodules abutting the pleura. The pleura is not spared, right? So that is random nodule. Now, so this is a comparison of the three types of nodules. So we have centrilobular nodules, which is the example. The clinical example is hypersensitive pneumonitis. As I told, you can see they are very homogeneously distributed, and there is a space between the peripheral most nodule and the pleura. So the pleura, the subpleural secondary pulmonary lobule is spared, and they are very homogeneously distributed, right? As opposed, random nodules, you can see there are nodules based on the pleura and also along the fissures. And they are also somewhat like homogeneously distributed, but they do not have to be. They can be a bit of heterogeneity, but the hallmark is there should be nodules touching the pleura. Then coming to sarcoidosis, so what is the difference between the random nodules and the perilymphatic nodules? Because perilymphatic nodules also have pleural-based disease. The difference is in perilymphatic nodules, they are clustered. They are not as homogeneous as centrilobular or random nodular distribution. In perilymphatic nodules, they are predominantly clustered in the central peribronchovascular bundle or along the peripheral peribronchovascular bundles. So that is the difference. So sarcoidosis is the example. Now, before I do away with the centrilobular nodules, so centrilobular nodules, there are two types actually. So that is treen bud. So you would have heard this term very often. Treen bud almost always suggests infection or aspiration. So you can see there is a tree, and on either side of the tree, there are buds. So the tree is formed by the respiratory bronchiole, and the buds are formed by either the alveolar ducts or alveolar sacs, right? So here you see lots of them. So there are various other parameters also to further categorize and characterize them. So I'm not going to go into those. Then the second type of central lobular nodules is the diffuse central lobular ground glass nodules, as you would see in hypersensitive pneumonitis, RBILD, and tumor emboli. So both these are central lobular nodules. That means they are located within the central lobular interstitium. Right. Now I'm coming to the fourth type of dominant pattern, which is increased lung attenuation. So you have either ground glass or consolidation. I hope that you know what is ground glass. So the ground glass is increased attenuation without obscuration of the underlying vascular markings, right? So there is no further any other definition to that. And that is opposed to consolidation, where you lose bronchial, where you lose all the vascular markings, but you can see the bronchial markings there. So all the vascular markings are obscured, and that is more denser, right? Okay, so the last dominant HRCT pattern would be decreased lung attenuation. Now, there are three causes for decreased lung attenuation. First one is cyst, second one is emphysema, then airway and small vessel abnormalities. Now, how do you know when you see translucent focus, whether it's emphysema or cyst? First thing is, cysts contain walls. Now, this is actually easier said than done to look for the wall, right? If you can like ascertain a wall around it, it's a cyst. In emphysema, especially in central lobular emphysema, you can't define a wall as such. And also, you should be able to see the central lobular or bronchovascular structures within the lucent areas. I don't know whether you can appreciate. I can see some very subtle nodules in the center of the secondary pulmonary lobule. So the lucent area is the emphysematous secondary pulmonary lobule, right? So it may not be easy to identify it in the first at a glance, but you have to look through it very carefully. Then you might be able to see one or two spared bronchovascular structures within the center of these lucent areas, right? So that is basically how you have to look for it. You have to look for a wall or absence of wall and the presence of spared like central lobular covascular structures, right? So there are three types of emphysema: central lobular emphysema, panlobular emphysema, and paraseptal emphysema. So I have shown you here four cases of central lobular emphysema in varying severity from of varying severity. So on the left side, you have a case of central lobular emphysema, which is of mild severity. And as you go on, you can see it gets more and more extensive, right? And on the right-hand corner, you see a very extensive and advanced case of central lobular emphysema. But the hallmark here is that however advanced is the emphysema in central lobular, how much advanced the disease in central lobular emphysema, still you would see some spared lung along the periphery. Here you can see some spared lung along the periphery and also sometimes scattered here and there. That is a case of central lobular emphysema. That is in contrast to panlobular emphysema, where you will not see any spared lung. So you'll see this very attenuated outlines of the secondary pulmonary lobule or vascular markings. Actually, you can't see the secondary pulmonary lobule as such. What you see is the attenuated vascular markings. But I have yet to see a case of panlobular emphysema here, because this is associated with alpha-1 antitrypsin deficiency. I'm showing this off to see the difference between panlobular and central lobular emphysema. Right. Then lastly, we have paraseptal emphysema. That is obvious. So it is along the pleura and it's like a palisade of this thin wall cyst. And it might come with multiple stacks as well, but the hallmark is they are thin walled and they are not associated with fibrosis. Right. Then the other types of diseases causing decreased lung density would be cystic lung diseases. This is just a basic introduction of the common types of cystic lung diseases. So the first one is PLCH, pulmonary lung cancer cell histiocytosis. So they have characteristic distributions, sparing the extreme bases. So the pattern is it spares the extreme bases. No disease, never ever, along the base. And the upper and mid zones have this irregular shaped, thin and thick wall cysts, sometimes nodules. So that is PLCH. Then comes LAM. LAM has diffuse distribution, not sparing any part of the lung, and the walls are very thin, and they can be of varying size. That is opposed to a PLCH. Then we have LIP, or lymphocytic interstitial pneumonitis. They are predominantly along the bases. They are associated with ground glass infiltrates or ground glass nodules. So ground glass nodules are not seen in either of LCH or LAM. So that is how we differentiate. And lastly, like this is very somewhat rarely seen, but Hod-Dubé syndrome. So they have a particular, the cysts are of particular distribution. They are peribronchovascular, periphyseal, and paramediastinal in distribution most of the time. And they have a tendency to basal lungs, but it's not very characteristic. Lastly, airway and small vessel abnormalities. Now, this is the most difficult and the confusing part of the HRCT patterns, right? So, so airway and small vessel disease cause what we call mosaic attenuation. So mosaic attenuation is a patchwork of regions of differing attenuation that may represent either obliterative small airway disease, occlusive vascular disease, and purely ground glass. Now, mosaic attenuation, okay, so the term that we use is mosaic attenuation, but then there is a term as mosaic perfusion as well, right? But in both instances, what you see is varying attenuation within the lung. So what is the cause? So how does it happen in small vessel disease? So when you have small vessel disease and some of the areas of the lung supplied by these diseased vessels are poorly perfused, right? Because of the poor perfusion, the lungs are lesser dense. So that is the reason for the mosaic attenuation. But since it's associated with change in perfusion, we call it mosaic perfusion rather than mosaic attenuation. When it comes to small airway disease, also the same thing happens. So you have areas of the lung where you have diseased small airways. So when the small airways are diseased, that segment of the lung is poorly ventilated. So when the lung is poorly ventilated, that segment is poorly perfused. So what happens is, again, there is reduced density of that part of the lung. So that is again mosaic perfusion. And then you have ground glass. So how do you differentiate these three from one another? Again, it's easier said than done. But sometimes it's easy to do away with ground glass, because in ground glass infiltrates, the vascular caliber in both the dark and the white areas would be the same. But in small vessel and small airway disease, the abnormal areas are the translucent lung, because both areas are poorly, the areas of the lung which are poorly perfused, either due to small vessel disease or small airway disease. How do we differentiate? You have to go for an expiratory film. So in expiration, what happens is, in case of small airway disease, the difference would be widened. And in small vessel disease, the difference will not change unless there is coexisting small airway disease. Right. So just to wind up that segment. So this is the commonest entity that we encounter, bronchiolitis obliterans, where there is bronchiolar narrowing caused by submucosal scarring and chronic inflammatory changes. And it's a common complication of lung and bone marrow transplant. And just to give an example of this small obliterative bronchiolitis. So if you can appreciate this, so there is varying attenuation within this lung. There are high density and low density areas. So I'll stop here and I'll take the expiration. And you should be able to see that there is exaggeration of the difference. So the difference is widened, right? So the black areas have become more black and the white areas become more congested. So that is a case of obliterative bronchiolitis or small airway disease. Right. So now we have done with what is the dominant HRCT patterns and where the disease is located within the secondary pulmonary lobule. So we have done those two. And then the third one would be, what is the longitudinal and the transaxial distribution of disease? Now, what do you mean by longitudinal disease distribution? Is the disease worse along the bases, or is there more disease in the upper lobes? So that is the craniocaudal gradient. Or in transaxial distribution, is there peribronchovascular disease, or is the disease subpleural in origin? I'll show you with the examples. So this is the longitudinal disease distribution. You can see in these patients with the NSIP and UIP. So there is a craniocaudal gradient. So there's less disease in the upper lobes and more disease. The disease gets worse towards the bases. So that is the longitudinal disease distribution or craniocaudal gradient. Whereas here, that you have more disease in the apices and less disease along the bases. That is chronic HP. Coming on to the transaxial distribution. So in cases of organizing pneumonia, that you have peribronchovascular disease distribution. So the disease extends along the bronchovascular bundle centrally, whereas in subpleural distribution, the disease is along the pleura. Right? It does not extend internally or towards the bronchovascular bundle. So that is the transaxial and transaxial and longitudinal disease distribution. So in diagnosis of or interpretation of HRCT, you need to know all these, where the disease is predominant, is it along the bases? If it is along the bases, is it subpleural or peribronchovascular? So when we report what we say is, so there is a fibrotic interstitial lung disease with basal predominance and subpleural distribution. Or there is a fibrotic interstitial lung disease with upper lobar predominance and peribronchovascular distribution. And that statement itself would say the disease, the diagnosis. Right. So I have literally done the most of the stuff that I wanted to talk about. But since we have some time left, I will show you some of the clinical cases, some of the patients from my collection with common ILD. Now, so this is just a list. We'll see whether we can go through some of these. Right. So now this UIP pattern of disease, UIP type ILD, that this is the commonest ILD that we encounter day in and out. So we know that it's not a disease, but a histological pattern of fibrotic ILD. So we call it UIP pattern ILD. So I have already spoken about this. UIP is fibrosis, and these are the three hallmarks of fibrosis: reticulation, traction bronchiectasis, and honeycombing. Right. So this is a typical example of UIP. So we start from the top. So you can see some disease, some like lines, some reticular markings as we go down. So there is a cluster of honeycombing, and then there's sparing of the intervening lung. And as we further go down, we see more and more honeycombing single layer. And towards the bases, you see a lot of honeycombing, and it's nearly filling the lung bases without sparing the extreme posterior bases, right? So what you have to look for is, okay, this is UIP type ILD. Is it secondary to connective tissue disorder? What are the things that we have to look for? The anterior subpleural lung. Is there fibrosis in the anterior subpleural lung? I think the anterior subpleural lungs are somewhat relatively spared, right? So this could well be a case of IPF, but that is up to the clinicians to decide after exclusion of other possibilities of UIP type ILD. So the basic appearance would be basal predominant, subpleural predominant, and heterogeneous. I said that you can see disease in the upper lobes as well, and there are skip lesions with this. There are skip areas, skip normal areas in between. So UIP is a heterogeneous disease with honeycombing reticulation and absence of features suggestive of an alternative diagnosis. So that is the typical UIP classification. I'll just skip this. These are the guidelines. I'm not very fond of these guidelines. They keep on changing, right? This is another example of the same entity. You can see there is like more disease in the upper lobes, and as you go towards the bases, you can see more and more disease, right? And then we call this is exuberant honeycombing. You know, exuberant honeycombing, that is extensive honeycombing, is a feature of CTD related ILD. And also this finding here, this is called the straight edge sign. So presence of straight edge sign that this is we encounter in UIP. So presence of straight edge sign is an indication that there could be an underlying CTD. So exuberant honeycombing and presence of straight edge sign is an indicator that there could be an underlying CTD. Same, I think, yeah, it's again a UIP. Right, we have like, so what the things that the area that we have to concentrate is actually the extreme posterior basal lung. So there is no way that you can have UIP with sparing of the extreme lung bases. So that is the pattern of UIP. Right. Now coming to, so that is the typical UIP. Then we have the probable UIP pattern. Now, probable UIP pattern, now, okay, like you can see that there is like near complete involvement of the extreme posterior bases. So it can be even very subtle. And then you have subpleural disease with, there are some bronchial ectasis, if you can appreciate that. And there is associated intralobular interstitial thickening, or what we call reticulation, but there is no honeycombing. Absence of honeycombing with all the other features of fibrosis and the typical distribution is suggestive of probable UIP pattern ILD. Again, you can look for the anterior subpleural lung for any involvement, which would be the case of CTD. I think this is also could be a similar one. So this is very subtle disease. You can see there's not much of, but still you can see that the extreme posterior bases are gone. Although there's not much of disease, still this is probable UIP because you see all the features of fibrosis with involvement of the extreme posterior bases. Then if you see fibrotic lung disease as here, like for example, if you start from the top, we have fibrosis in the apices. And as we go down and down towards the bases, there are some scattered fibrosis. But as we come to the extreme posterior bases, there's no fibrosis. So this is a case of fibrotic ILD indeterminate for UIP. So that's part of these classifications only, right? Right. Okay, I've spoken to you about these already. Right. Then non-specific interstitial pneumonitis or NSIP. So it's more uniform than UIP actually. And it will be a combination of fibrosis and acute inflammation. So what we see here is, so there is somewhat sparing of the extreme bases. You don't see in the extreme posterior bases. And also the subpleural lung is somewhat spared, if you can appreciate it. So there is an area of subpleural sparing. And the diseased lung, so there is ground glass, there's somewhat ground glass with traction broncholectasis and some patches of disease elsewhere. But your diagnosis would be based on what you see along the base here. So ground glass sparing of the extreme bases, extreme subpleural lung, and the extreme bases, this is NSIP. So this patient has somewhat more extensive disease. Again, there is extreme this posterior basal involvement. Again, it's somewhat homogeneous. Now, when we call this, like we can't expect it to be 100%. So there are some areas of sparing here, but actually, I don't want to confuse you all with this is our patches of organizing pneumonia actually, because usually NSIP comes hand in hand with organizing pneumonia. So we have subpleural, like lower zone predominant ground glass with traction broncholectasis. And then there's these areas of peribronchovascular, like we cannot actually, I do not have any examples of an NSIP where there is no component of organizing pneumonia. So the organizing pneumonia usually present in most of the patients with NSIP. So then if you examine this patient in the coronal plane, this is what you would say. So this is quite like opposite to the straight edge sign in UIP. This is like a pyramid, right? Straight edge is like here, like it's across the lung base. It's a straight line. So NSIP, in NSIP, we see this pyramid shape in the coronal plane. So that is one feature to differentiate it from UIP. Right, so we'll just close that. Do a few cases of organizing pneumonia. I'll show you the cases only. So I hope that you have heard this atoll sign. So this is a nice atoll along the base. You have peripheral consolidation and central ground glass. And these are the thickened perilobular interstitium. You can see this, the linear, that arcade, sorry. The linear arcade like the picture. So that is arcade perilobular thickening with what you call the atolls. And then when you go up, again, you see this peribronchovascular infiltrates. So that is also a presentation of organizing pneumonia. So that's a nice case of organizing pneumonia. This is another form of presentation of organizing pneumonia. This is what we used to do during COVID pandemic. So here, when I go up and down, I hope that you can appreciate the secondary pulmonary lobules appearing and disappearing. So here, so what you see is these small lobules of something like a lobule appearance is the secondary pulmonary lobule with the thickened interlobular septum. And we call this appearance the perilobular interstitial thickening. So it's, I told you at the beginning that interlobular interstitium and the perilobular interstitium both are the same, but the involvement in organizing pneumonia, there is some change in the secondary pulmonary lobular outlines. They become more rounded rather than being very sharp. That is due to what they say is in organizing pneumonia, there is slight infiltration of the adjacent intralobular interstitium as well. So this is nicely demonstrated. You can see the secondary pulmonary lobules, these lobules in the basal lungs. So this is the case of, again, organizing pneumonia. Another case of organizing pneumonia. Again, you can see this perilobular outline of the secondary pulmonary lobule. Here you can see it, here you can see that. And so organizing pneumonia would have perilobular distribution and peribronchovascular distribution, as you can see all over, like centrally you can see peribronchovascular distribution. I think that would be enough for organizing pneumonia. So there are varying forms of organizing pneumonia, to be honest, because this is something that you can consider in most of the instances and also easily missed, right? So I'll just go to another form of ILD. So hypersensitive pneumonitis. Now this is not an interstitial pneumonitis, but we usually consider it under this idiopathic interstitial pneumonias because of these HRCT features. Now, in the current classification, we talk about non-fibrotic and fibrotic HP rather than acute, subacute, and chronic. So that is the newer classification since 2020. So there is this thing called the 3-density sign. So the hallmark of the disease is ground glass centrilobular nodules. Now I have already shown you a case. So 3-density sign, I think people are like this, clinicians are very fond of like looking for this 3-density sign. So 3-density sign can be appreciated only in well-interpreted CT images, not in expiratory images. So what does it mean? It has normal lung, high attenuation, that is ground glass lung, and lucent lung, that is air trapping. And they are sharply demarcated. So this is a case of a subacute or non-fibrotic HP, hypersensitive pneumonitis with 3-density sign. So you have 2 densities here. So you have air trapping. So in HP, the air trapping would be lobular. We don't see large areas of air trapping. So this is air trapping. Then we have ground glass lung. And somewhere like in between, you have like, can you see this normal lung? So you have normal lung, air trapping or translucent lung, and high density lung. So that is the 3-density sign. And then you have to look for the trachea. Is it a good inspiration? Yeah, it's a good inspiration. So this is a typical 3-density sign in a patient with non-fibrotic hypersensitivity to pneumonitis. So this ground glass nodules are very homogeneously and tightly packed. Actually, you cannot differentiate nodules from one another, right? So that's the typical case. Then we see chronic or fibrotic HPs. So here in those areas, in cases that we have to have expiratory, no, this is again subacute or non-fibrotic. Now this patient is a recent CT of this patient had very extensive disease. But here in the current one, like we can barely see the nodules because there's significant interval response to treatment. Then we did the expiration. In expiration, we can see there is a lot of air trapping. So this patient is now developing fibrotic HP. So air trapping are lobular. So there are small, so that is typical of HP. I'll show you one case of fibrotic HP right here. So there is fibrosis. So we start from the bottom. So the basal lungs are fine. So there's no fibrosis or anything. As we go up and up, we can see there is this fibrosis. So this fibrosis in HP is peribronchovascular and perilobular. Right? And in expiration, what happens is, take this up, right? In expiration, you see a lot of air trapping. Lobular air trapping, not large areas of air trapping. Right? So, so these four diseases like UIP, NSIP, HP, and organizing pneumonia is the commonest ILDs that we see day in and out. And there are like a number of other ILDs that we encounter on a daily basis. But I have not, because I think this is more than enough for this stage. So since that we are run out of time also, I'll confine my talk to only this level. I have some other like cases as well, but these are very rare. And also there's a lot of overlapping between the HRCT findings. So now that you have some idea about the basic idea about the typical HRCT findings and the commonest HRCT patterns, I think that you can build up your knowledge based on that, rather than me trying to confuse you any further. So I'll just actually I've shown you like there are two cases that I want to. Is it okay to have few more minutes, Suranga?
Yes, of course. Yeah. Get him. Yeah. Thank you.
This is because this you have to. So this is one of the like commonest HRCT findings that we encounter. Now we were talking about nodules. So this is random nodule in case of miliary TB, right? So why we say miliary TB is very convincing, because we see areas of cavitation and consolidation as well. So that is a typical case of miliary TB. That's another. And this is also because I wanted to show these two cases. So this is again a miliary TB. So miliary TB shows random nodules, which are more or less homogeneously distributed. And I hope that you can appreciate the presence of these pleural-based nodules. Here you can see pleural-based nodules. So that is why we say it's random, right? And then the contender to this would be this one here. So again, you have pleural-based and fissural-based nodules, but they are more clustered, right? It's not like in random, because why I stress this point is in clinical practice, we have encountered cases which is very difficult to differentiate miliary TB from sarcoidosis, and you know the diagnostic implications. So we have to very closely look for like particular signs of sarcoidosis, such as this peribronchovascular nodularity, if you can appreciate that. Along the bronchovascular bundle, it looks like what we call a katuatta. So it's very typical of this sarcoidosis, but it is easier said than done, because we have come across many cases. We have mistaken sarcoidosis for TB and the other way, vice versa, right? And so this patient actually, this is a doctor who presented with very constitutional symptoms. We had some like doubts. We were initially thinking in light of sarcoidosis, but we had some doubts because could it be TB, right? So this patient actually had to undergo a biopsy as well, but ultimately it turned out to be sarcoidosis, but it's not a straightforward case. So that is why I want to show you these two cases. Right, okay, then I'll stop there. So just winding up my talk. So what you have to keep in mind is there is a thing called pattern approach. So where you have to look for the distribution of the disease within the secondary pulmonary lobule, and then the dominant HRCT pattern and the longitudinal and transaxial disease distribution. If you can sort that out, you can build up your knowledge based on that, and then you can read up, and then, like, you know, if you come across something, then you should be able to work it out. But keep in mind, there are like very complicated cases where there are combinations of patterns and there is no like diagnosis act yet for those patterns, right? So so that is all I have to tell you all. Are there any questions, or is there a time for any questions?
Yeah, thank you, Dr. Sumudu. Then there are a few questions. So one question is how to differentiate methotrexate-induced ILD in rheumatoid arthritis from ILD due to the rheumatoid arthritis itself.
Methotrexate-induced
ILD in rheumatoid arthritis. How to differentiate methotrexate-induced ILD from rheumatoid arthritis ILD?
Actually, I don't have a clear answer for that because rheumatoid arthritis induced ILD, what we commonly see is organizing pneumonia. So organizing pneumonia also would come in different patterns in different diseases. For example, in like COVID, the type of organizing pneumonia that we encountered is quite different from what we used to see. So similarly, in rheumatoid arthritis, also there is a pattern of organizing pneumonia, but unfortunately, I do not have a picture of that. And in methotrexate induced ILD, they also have a component of organizing pneumonia and as well as what is this NSIP, right? So I also have no clear idea as to how to differentiate these two from these two. But all I know is that rheumatoid arthritis, they come predominantly with the organizing pneumonia, and the other one could have organizing pneumonia and NSIP combination. So for that, actually, I had, as I told you, rheumatoid arthritis organizing pneumonia has certain morphology. But I showed you some morphologies, but that is not there. Actually, I do not have a picture of that.
Okay, thank you. And there is another question. Please explain about ARDS pattern.
ARDS pattern. Actually, I skipped that part because I thought there's not much of time. Just give me a second there. I have some slides there. Am I sharing the screen now, or how do I? Right. So ARDS. Okay, I'll start from here. Now, ARDS is actually a clinical condition, like it's not radiology. So I'll start with this, like, since that you want some answer for this. So now, because there's no AIP and ARDS, so ARDS could be primary. So the primary ARDS could be due to acute interstitial pneumonitis. Right? So they both share the same radiological features. There is no differentiation. Only thing in arts is there is a secondary cause. But in AIP, there is no secondary cause. Like, so it is idiopathic. So I will talk about, so I have some pictures of AIP, right? Which is the idiopathic version of arts, right? Radiologically, they are the same. Okay. So what we see here is, so we have phases. So even in arts, this is how it starts. So we start with this acute permeability, acute phase, where we have like diffuse ground glass, right? So in acute phase, in addition, we can have sometimes this ground glass, which is basally predominant because that is like because of the dependent nature, and there would be areas of sparing in the non-dependent lung. As the disease progresses, you will see more and more consolidations and ground glass along the bases, and there would be areas of sparing in rest of the lung, right? So this is what happens in acute phase. What you do not see in acute phase is you will not see fibrosis and you will not see bronchial dilatation. Okay. So as we go on, as the disease progresses, what happens is, so that would be in the organizing phase. So there would be dilated bronchi. Now we are not going to call this bronchiectasis because this could be reversible when the patient improves. So we would have sometimes segmental bronchiectasis, or there would be diffuse, but this acute phase changes and organizing phase changes may coexist, right? So then we'll have these areas of irregular consolidations, so which could be the developing organizing pneumonia changes. So organizing pneumonia is response to lung injury, whatever response to whatever lung injury, right? So we see these irregular areas of consolidation, and then we have ground glass and then pleural effusion as well. And this is more extensive. You see more fibrosis and some distortion of the underlying lung parenchyma. So that is the organizing phase that will start beyond second week of disease. And in like few weeks or months' time, if the patient is lucky enough to survive the acute episode, this is what you would be left with. Either you would have a perfectly normal lung, which is like, which has reversed back to normal, or you will have these patches of ground glass, which could be the residual organizing pneumonia or response to previous lung injury, or there would be these larger areas of airspace infiltrate with air trapping, again, residual organizing pneumonia patches, and there would be some fibrosis at the sites of the initial lung injury and also along the bases, as you see here. So that would be the temporal resolution of AIP, which is the idiopathic variety of ARDS. I hope that I've answered your question.
Yeah, thank you. And I think there are so many questions. So with the time constraint, there is one question about how to differentiate pulmonary edema from hemorrhages.
Pulmonary edema from hemorrhages. Okay. Right. So I have spoken about the interlobular septum and the center of the interlobular septum. Now, I hope that you can remember that I showed you a case of alveolar proteinosis, right? So in alveolar proteinosis, what happens is, like, so you have the secondary pulmonary lobular thickening with central ground glass. So that is somewhat similar to alveolar hemorrhage. So you have ground glass in the secondary pulmonary lobule with thickening of the interlobular septum. So that is basically what you have, the earliest version of pulmonary hemorrhage. But as it progresses, the ground glass will become more and more denser and it will become airspace. Then it will be consolidation. Then you will not see this secondary pulmonary lobular architecture. But at the start, how it starts is ground glass with interlobular septal thickening. So if I could get back to that slide again. Where was it? Yeah, so this is now what you see here. So this is ground glass, right? So blood appear, hemorrhage, alveolar hemorrhage appear as ground glass. So as it progresses, what happens is the intervening secondary pulmonary lobule also get thickened. So this actually case is a case of pulmonary hemorrhage. So there are differentials for this appearance. One thing is pulmonary hemorrhage. So you have to differentiate it with the history. Pneumocystic cerevisial infection, that is one thing, right? And the other one is hypersensitive pneumonitis as well. So yeah, so it's basically ground glass. Ground glass, as it further progresses, you will see interlobular septal thickening, and if it further progresses further, it will be consolidation, and you will not see the secondary pulmonary lobular architecture.
There are so many questions, and so I will just ask one question. What is crazy paving pattern?
Okay, crazy paving pattern. Good that we are there. Here slide. I think I could not like mention that term. So this is crazy paving pattern, right? So secondary interlobular septal thickening with ground glass. So we see crazy paving pattern in alveolar proteinosis and PJP infection. So those are the two main conditions, and also sometimes in pulmonary hemorrhage also. You can have crazy paving, but the typical example is alveolar proteinosis, as I have shown you here. So this is crazy paving.
So I will conclude with this question. Can tree in bud seen in only sarcoidosis? Can tree in bud seen in sarcoidosis? Is it only in TB?
Yes. If you have secondary infection with sarcoidosis, you may see, but otherwise, tree in buds are, I think I have given you the statement. If you see tree in buds, it's either infection or aspiration, nothing else. So if you have a patient with sarcoidosis and you happen to see tree in buds here and there, this patient either has secondary infection or patient had a recent episode of aspiration. So sarcoidosis is not a feature of, tree in bud is not a feature of sarcoidosis.
Okay, thank you, Dr. Sumudu. And they are asking this PowerPoint presentation also. So if the Dr. Sumudu is willing and agrees, then we can get this PowerPoint presentation. So I think with that, I would like to conclude this pre-Congress workshop on HRCT interpretation. So I would like to express my sincere appreciation for the wonderful, elaborative and illustrated talk on HRCT interpretation. And I would also like to express my sincere appreciation to Dr. Suranga, the President, Sri Lanka College of Internal Medicine, for the initiation of advanced medical diagnostic webinar. So we hope that we will be continuing this webinar monthly or maybe in 2 months. And I would also like to express my thanks to the Gates Pharma for the logistic support. Thank you very much for the audience as well, for the participation. Thank you, Dr. Sumudu and Suranga and all. Very good night to you all. Thank you.
Thank you.